Morning. I want to give it just a couple more minutes only because cardiac rhythm interpretation is already not easy. And so I like to try and start from the beginning with everyone. So I just want to give everybody a couple of minutes. Ugh, my allergies are horrible today. All right. All right. How's everybody doing this morning?
Good. Okay, how are you?
I'm doing okay. It's the middle of the week. Woo woo, hump day, right? All right. How was your VSIM yesterday? Okay. So. Okay. All right. So I can't remember. In previous classes, have you guys gone over cardiac rhythm interpretation previous?
No.
So not at all, not reading strips at all. All right. Well, we're going to have fun today. All right. So this really is, people get very I think overwhelmed and freaked out type of thing by when we start doing this. But it really is, if you just like follow the rules, it will help you. And there's like definitely a system that okay, sorry. Okay, so there is a system to this, but yesterday or not yesterday, you know what I meant, Monday, we talked about the electrical or conduction system of the heart. And so when we read an EKG, that's really what we're interpreting, is how that conduction system is working. Okay. So remember, we talked about this on Monday, that our SA node is our primary pacemaker, right? That's where normally we should get our impulses coming from. Okay. And the inherent rate of our pacemaker of our heart, or SA node, is at 60 to 100 beats a minute. Below that, we have our AV node. It creates a delay. Basically, the delay is to help those atria to fully empty into the ventricle. And that's why that AV node creates that small delay. Mind you, we're talking about fractions of a second in delay. Okay. But that's what it's there for. If our SA node is not working and does not initiate the impulse, then the AV node is going to take over. The inherent rate of our AV node is 40 to 60 beats per minute. You will hear people call the AV node the gatekeeper. And when we start talking about atrial dysrhythmias, we'll talk about why the AV node is called the gatekeeper. Okay. It's basically there to try and prevent too many impulses from getting to the ventricle if the atria are not firing correctly. Next, we have this. Oh, it would help if I share my screen. I'm not awake this morning, apparently. All right, let's try this again. All right, can you guys see my PowerPoint now?
Yes.
Okay. So the bundle of His was what we talked about. So here's our SA node, our AV node, and then our bundle of His. We have the left bundle branch and the right bundle branch. Okay. So the inherent rate of the bundle of His and the bundle branches and the Purkinje fibers are 20 to 40 beats a minute. So you can see that that is barely keeping us alive, right? If the AV node and the SA node aren't working, that inherent rate of the ventricles is barely going to keep somebody alive. Okay. So we don't want these things pacing our heart. We want the SA node, or worst case scenario, the AV node. And this is your pathway. Your SA node initiates your impulse. It travels to the left atria, and then it travels down these pathways through the right atria to the AV node. The AV node slows it down for a fraction of a second. Then that impulse travels into the bundle of His, to the right and left bundle branches, and then to the Purkinje fibers in the ventricles. So, any questions about this, the conduction system? You need to understand it, because when we start talking about reading the EKG, it's really about what is going on in that conduction system, and then what that makes the heart do. Okay. So we've already talked about these, but I just want to reiterate them. Your cardiac output is the amount of blood ejected from the heart in 1 full minute. It is determined by the heart rate multiplied by the stroke volume. The stroke volume is the amount of blood ejected from the heart in 1 beat. Okay. Heart rate is the amount of times the heart beats per minute. Your ejection fraction is the amount of blood pumped out from the ventricle with each contraction in a percentage. Stroke volume is in mLs. Ejection fraction is in a percentage. And then that contractility is the force and strength of the contraction of the heart muscle. So how much elasticity and strength does it have in that contraction? Refresh. Preload is the amount of blood in the ventricles during diastole, or at the most relaxed state, right before contraction. Afterload is the pressure that the left ventricle has to overcome to pump out the blood into the circulation. Oh, and before I forget, Miss Angie is coming on at 1. She's going to take over at 1, and she's going to do the math with you guys, since you have your first math test today. That she's going to review the math with you. I asked her to do it because, I'll be honest, I am not, like, dimensional analysis is not my inherent go-to. And so I thought she's going to be teaching part of this course anyways. I asked her if she could come on and do the math with you guys, and she said yes. So at 1, she's going to come on. So for that last hour, she's going to go over the math with you guys, okay? I want you to have that from her before your first math test, so it's nice and fresh in your brain. And then if we don't get through all of EKG, we will finish it up on Monday. But hopefully we should be able to get through this.
Miss Brisman,
Yes.
I sent you an email regarding my math. I don't know if you had time to review it.
I saw the chat. I saw the message you sent me.
Okay.
But I haven't had time to go look at the math sheet. No.
Yeah, because it's saying incomplete when I completed it. So I don't want them to say I didn't complete it, so I won't take exam today.
Okay.
All right,
Will
thank
you
you.
let Miss Angie know that too, please?
Okay, thank you.
Stella, I think
Yep.
I think if you got it all right, that's what it says is completed. Because mine says the same thing.
Okay, it says incomplete on mine, and then it shows me
It
only
says
numbers
incomplete or complete.
incomplete.
Oh, I don't know about that. Did
Yeah,
you try
I did every question and I submitted it. It only showed me number 6 and said incomplete. So I couldn't go back to do all because it's not showing me everything. So it's only showing me number 6. So that's why I sent her email to see if she can review it from that side.
Okay, I'll have to try and take a look at it.
Thank you.
Yep, no problem. All right, any questions about this? This should have been a review, remember, right? Because we talked about all this on Monday. Okay. All right, so this is what EKG paper looks like. And I use the quotes because almost all places now, except for your 12 leads, 12 leads are still printed in most places. But your general monitors that your patients are on, back in the olden days, we used to have to start our shift out and we would print what's called a rhythm strip for our patient. And then we would interpret that rhythm strip using a tool called, what did I do with it? I know I brought it. Oh, there it is. We would use a tool called calipers. Has anybody heard that before or know what I'm talking about, what calipers are? Nowadays, everything's electronic on monitors, but I will show you. I actually have, I'm going to show you something funny. These are very beat up, but these are my original calipers from nursing school. And I stabbed myself with them. And I had a little card that I used to carry around with it all the time because technically the way we're going to show you to count heart rhythm is not completely accurate. And so there was a little card and it said if I had so many blocks between my R and R, this is what my heart rate was. And I used to, you can tell this is pretty beat up. But we would take our calipers, so these are calipers, and you would, and they're very sharp as I poked myself with the one. and you would put it on the first part of what you're measuring, and then you would put the second piece on the other part that you were measuring, and then you would count your squares, and we're going to talk about that. But these are what calipers are. So if you ever hear somebody talking about calipers, and it's so old that my case, the cover for the sharp things is broken. That's how I just ended up stabbing myself. But I since have a newer pair, so these are a better pair of calipers. And we use these to see if a rate was regular, irregular, and so just a bunch of different stuff. But we would have to print off a strip for our patient that was on monitor, and we would have to use our calipers, and we would have to interpret that strip, meaning we would have to go and do all these things that we're going to be doing today to determine what rhythm our patient was in. Nowadays, all of your monitors, almost all of your monitors, are electronic. She asked about a study guide or blueprint. I can kind of do that, but I will just give general topics. Because you have to be able to pass NCLEX too, and I don't know what's on NCLEX. And so I make sure that you try and understand the concepts and not memorize what you are worried about is going to be on this test. So, but we will talk about this stuff. Basically, if I've covered it in lecture, I pretty much say you should know it. So, what I've covered in lecture, you should know. But yep, I can do a breakdown of the topics. No problem. So this EKG paper, when we're looking at it, this is a strip. So each of these little bars up here at the top, you see these? Those are 10-second intervals. So we have 1, 2, 3, 4, 5, 6, and this is 7. Typically, it should be in 6-second intervals. All the boxes are, sorry, this is a second. Each box is a second. And so they're going to be 6 of these little bars right here. And that will give you 6 seconds. So when we look at a strip, we're typically looking at a 6-second strip. So that's why I said when we measure things, we're measuring in fractions of a second. Okay? So each of these lines here
What
is a,
lines are you talking about
Yeah.
in that?
so at the top, can you not see my mouse?
No.
Okay. I thought if I shared screen, you could see my mouse. Let's see if I can annotate. Here we go. Okay. Can you see now? Can you
Yes.
see? Okay, beautiful. All right. So each of these lines right here is a second between this line and this. So here to here is 1 second. And so in this one, you'll see there's 1. So this is a second. This is your second second. This is your third second. This is your fourth second. Then your 5th second, and then your 6th second. So if you were doing a 6-second strip, you're going to measure from here to here. That's where we're going to look. Okay. And we're going to, the next slide, we're going to go to, it's going to, each of these little, so in this second, in each second from here to here, you have 1, 2, 3, 4, 5 big boxes. Okay. And each side, and inside each big box, you have little boxes. And we're going to, in the next slide, it zooms in to show this. But each of these have measurements in time. So when we go to the next slide, I have to turn my annotation off. Give me a second. Let me figure out. Okay. And then let me turn off annotate. Okay. So now when we were looking at this and I was telling you about the inside of, between the things and then the big blocks and then little blocks. So this is a big block right here. Hold on, I'll annotate. This is your big block, right? And you can see another one would be here. This would be a big block. So it's your thicker pink lines. Inside each big block are these little blocks. And each little block is 0.04 seconds. Each big box is 0.2 seconds. Okay. So that's how you get, if we come back to this paper, that's how you get that there is a second between here and here. Because if this is 0.2 seconds, this is 0.4 seconds, right? 0.2, 0.4, 0.6, 0.8, and then we're at 1. And that's how you get that this is 1 second. This is your first block. That's going to be 0.2, 0.4, 0.6, 0.8, and then at the end of this block, we hit 1 second. Everybody with me?
I'm a little bit confused because I thought those marks, I thought the little boxes were 1 second each, and then the marks at the top were your 6-second intervals.
No, the marks at the top are this between here and here is 1 second. And then between here and here is 1 second. And then between here and here is 1 second. And then between here and here is 1 second. So then you count that's 1, 2, 3, 4. And then this would be your 5th second right here. And then your 6th second right here. And then each of these big boxes is going to be 0, I can't write with this, 0.02, I can't write, or 0.2, my God, Brandy, stop it, 0.2 seconds, 0.2 seconds in this block. So then if you count between this and this, you will see that the first block right here is going to be 0.2. 0.2 plus 0.2 is going to be 0.4. 0.4 plus another 0.2 is going to be 0.6. 0.6 plus another 0.2 gives us 0.8 of a second. And then when we add our last box of 0.2, we get 1 second. 8 plus 0.8 plus 0.2 is going to be 1 second. Hold on just a second, guys. Give me a second. Okay, sorry guys. That was Miss Angie and Stella. She said she's gonna look at the math stuff in Brightspace and she'll text me back. So
Okay, thank you so much.
yep. Yes, you're right, Stella. You can also do the 0.2 times the 5 boxes and you get 1 second. Either way, that will get you the same answer. And then let's see, clear. Okay. And then, so when we go back to this slide, that's what it's showing you. And then within this big box, which is our 0.2 seconds, within that large box, there are these small boxes, and each small box is 0.04 seconds. And so if you count, there's 1, 2, Brandy, annotate. You can't see my mouse. Okay. If you count 1, 2, 3, 4, 5, there are 5 small boxes and 1 big box or large box. And so if you take 0.04 and multiply it by 5, it is going to give you 0.2 seconds. And that's how this paper is all broke down. Now, like I said, very rarely do you actually see strips, except for 12 leads on paper, printed on paper anymore. The majority of the time, this is all electronic. You actually go into the screen and you pull a strip up and you have electronic calipers. So you just like mark from one spot to the next spot and count on your electronic screen, which makes it a little easier because the lines are easier to see. So, but that is how we get all our time increments when we are talking about EKGs. So if we go, let me turn off my annotation. All right, so this again shows you that there is a 1 second between those, what we call tick lines. Okay. And if we have 1 second between each tick line and we have we measure a 6-second strip. So this would be 1 second, Brandy. This would be 1 second here. This would be your second between this one and this one, your third, your fourth, your fifth, and your sixth. So you see why it says you're going to measure from there to there, right? From here to here, because that's your 6 seconds. Now, when we measure 6 seconds, we do 1 minute is 60 seconds. So whatever we get in 6 seconds, when we're talking about heart rate or QRS complexes, we're going to multiply that by 10 because 60 seconds is a minute. And that gives us our heart rate. So if we take a 6-second strip and we multiply whatever QRS complexes we have in there by 10, that will give us our heart rate. And we're going to practice lots of these. Okay. All right. So when we look at our EKGs, there are parts of the EKG that we are going to identify or name right away. So the first one here is our P wave. Okay, that is this little bump right here. Okay, our P wave is our atrial depolarization. Okay, depolarization is a contraction. So this is where our atria contract. The P wave is our atria contracting. Our QRS, here's Q, R, and S, okay? So it's called a QRS complex, and that is ventricular depolarization. So ventricular depolarization is ventricular contraction. Now, while our ventricles are contracting, our atria are relaxing. So what's going on underneath all of this is that your atria are also repolarizing. So the ventricles contract, the atria relaxes. And that's what's going on when we look at the QRS complex. Okay. Right here. And then we have our T wave right here. Our T wave is ventricular repolarization. So that's when our ventricles relax. So the first thing we're going to come through and we're going to look for a P wave. Then we're going to look for our QRS complex. And then we're going to look for our T wave. Those are the three things that we should be looking for on an EKG. Those are our three basic things we're looking for. Okay. Now we start measuring things that are going to tell us different stuff. So the first thing we're going to measure is called the PR interval. This is where I was talking about you would take your calipers and you would start at the very beginning of your P wave. Okay. And you measure until the very beginning of the QRS complex. And we call that the R interval. A normal PR interval should be between 0.12 to 0.2 seconds. That is a normal PR interval. Okay. The next thing that we measure is going to be the QRS complex. And so that starts at the beginning of the QRS complex, so where we ended our PR interval, and ends at the end of our S wave. Okay. So from the beginning of our Q to the end of our S is our QRS complex. Normal measurement for a QRS complex is 0.06 to 0.12 seconds. Oops, sorry. Okay. And then the last thing that we're going to look at or measure is called the QT interval. Okay. So our QT interval starts at the very beginning of our Q wave right here and goes all the way to the end of our T wave right here.
Miss Briesman, I'm sorry to. Corey said he's waiting to be let into the class.
I
Sorry.
did let him in. I'm sorry. Yeah, I had missed it earlier. I have let him in, but thank you. I did go see him. Thank you. And so this QT interval is the measurement between when the ventricles start to contract and when they are at the end of relaxation and are ready to be depolarized again and have another contraction. So while your cells are repolarizing, getting ready for the next contraction and relaxing, which for our ventricles is our T wave, they cannot take another electrical impulse. If an electrical impulse comes in this part of the cardiac cycle, okay, it can put that patient into cardiac arrest. It will put them into complete cardiac arrest. So when we lengthen this period out, some patients may have that naturally. There are a lot of drugs that lengthen this. And when you study pharmacology, you may even see where it says like a prolonged QT interval, right? As a potential side effect. Does anybody remember seeing that as a potential side effect? In your,
Yes.
yeah, yeah. And so when that, what's that?
Wasn't that Torsades?
So no, torsades is a little different, but we will talk about torsades. But yeah, so actually what happens here is, so when that interval gets lengthened out, then we have a higher chance of getting an impulse in this section and somebody going into cardiac arrest. So do you guys remember the football game, the Cincinnati Bengal football game where the player went into cardiac arrest on the field? Do you guys remember that? It was all over the news for quite a while. That's what happened. So I'm not saying his QT interval was lengthened. It may or may not have been, but what happened is he took a hit to the chest right in this section right here of this, like between this ST segment and the end of his T wave. So he took a hit to the chest at exactly the right time. A hard hit to the chest is the same thing as it mimics an electrical impulse or a shock, and it put him into cardiac arrest. So that's what happened. And so this is why when we give medications that can potentially prolong the QT interval, we want to make sure that they don't already have a prolonged QT interval, because we are increasing the risk for sudden cardiac death. And that's why it's important. Okay. Normal QT interval is 0.35 to 0.45 seconds. Okay. So when we're looking at our EKG, the first thing we're going to look for is our P wave. Okay. Then we are going to look at our QRS, which is this right here. I know my line isn't straight, but you are following me. That's our QRS complex. And then the next we're going to look at is our T wave, right? This is what we're looking for, a T wave. These are the waves we want to find, the waveforms. P, QRS, and then T. When we go to measure, we're going to measure our PR interval, which is from the beginning of our P wave to the beginning of our Q, and that is our PR interval. Okay. Normal PR interval is 0.12 to 0.2 seconds. You guys will have to memorize these. You have to know them. Okay. The next thing we're going to measure is our QRS complex, and our QRS complex starts at the beginning of our Q and ends at the end of our S. Okay, right here. And normal QRS complex is 0.06 to 0.12 seconds. And then the last thing we're going to look at is our QT interval. And that starts at the beginning of our Q wave and ends at the end of our T wave. A normal is 0.35 to 0.45 seconds. There's one other area I want to draw your attention to, and that is this ST segment right here. Okay. Remember when I said that we were talking about MIs on Monday, myocardial infarctions, and I said there's STEMIs and non-STEMIs. And the STEMI is an MI that causes an ST elevation. And that ST elevation you're going to see is on your EKG. And so what happens is, instead of this line right here, let me see, this line that starts here, it's called your baseline or isometric line, okay? Your waves should come back to that isometric line. Well, what happens is when you have an ST elevation, this line right here goes away and it will come up and you don't see it. So this line goes away and it becomes like one big T wave. You can't see where it goes back to that isometric line. And that is called an ST elevation, because the ST is not on the isometric line, the ST segment. It comes up. And what that's telling you is that your ventricles are are not really, the depolarization and repolarization process is messed up. It's not working correctly. And remember, if we have something happen during ventricular repolarization, sorry, I was just reading Miss Angie's text message, and I'll share that with you in just a second. So if that repolarization doesn't happen correctly, we have increased chance of sudden cardiac death. And that's why that's very important. That's why these patients have to go to cath lab very quickly. We have to get this fixed. Okay, so Miss Angie just said to me that she said, Miss Pam is looking into why if they got a 90 that it says incomplete. But tell them as long as they got a 90, they can test today. So if you do not get that quiz done today, you are not going to be eligible to sit for your math exam. If you did not get a 90 or higher before, then you need to get that done before you go for your math quiz or math test. You have to have a 90 or 100% to be able to do the math quiz. So you need to take it again. Okay. She said, if you don't have it done by the time I come to teach math, I'm going to kick them out of class while I teach because I'm going to review the worksheet with them. So we will take a break today. I would suggest you try and get in there and get that done on break. Okay. So I'm just letting everybody know that's what Miss Angie said. It doesn't tell you your percentage. Okay, hold on. Let me see. All right, give me a second. I am messaging you right now, Alexandria.
Miss Breslin, did you figure out how to put the things on Brightspace, the lectures? Because
No,
I
I
still don't
was going to ask Miss.
understand this, and I want to go back and try to grasp it.
What's that?
I don't understand this stuff that you teaching right now,
Okay.
and I want to rewatch it a couple times.
Yeah, I'm going to try and get them up. I know the one is ready, and I just have to remember how to do it. I'll probably ask Miss Angie to help me, because I think it's been a bit since I did it. So, but it is on my list. I'm also going to have my tutoring times up by the end of today. So I have my sticky note. Okay. So, do you want me to clear this and go back again?
Yes.
Okay. Okay. So, when we first look at our EKG, we are going to look for the first thing we're going to look for is our P wave. And this is this little bump right here. Okay. The second thing we're going to look at is our QRS complex. So that's right here. This is our Q. This is, oh, bless America. I can't. This is our R. And then we come down into our S. Okay, so that's our QRS complex. And then the last waveform we're going to look at is our T wave. And that is right here. This is a normal complex. This is what a normal complex should look like. Okay. So P wave, QRS complex, T wave. Once we identify those, then we're going to start measuring our different areas. The first area we're going to measure is our PR interval. That starts at the beginning of my P wave and ends at the beginning of my Q wave. And so I am going to count the boxes in between these. That's how I'm going to get my time. I'm going to see how many boxes there are. Okay. Normal PR interval is 0.12 to 0.2 seconds. Everyone see that? Okay. The next thing that we're going to measure is our QRS complex. Our QRS complex starts at the beginning of our Q wave. Hold on just a second, guys. Sorry. Okay, so it starts at the beginning of our Q wave and it ends at the end of our S wave, right there. Okay. So we're going to measure between those two lines. We're going to count how many boxes, and it should give us a time between 0.06 and 0.12 seconds. So that would be 1.5 to 3 small boxes. Okay. The next thing that we're going to measure is going to be our QT interval. Our QT interval is going to start at the beginning of our Q wave and end at the end of our T wave. And we're going to measure or count how many boxes in between these. And it should give us a measurement of 0.35 to 0.45. That's here. And your QRS complex is here. Okay. And we're going to practice some of these. We'll end up practicing. And hopefully once we start practicing, it'll help. Hold on just a second. Okay, sorry about that. All right. So let's move on. Everybody take a quick break. Sorry about that, guys. Okay. So that is all the things that we're looking at when we look at the EKG. Okay. Okay. So this is where, again, it's going through the process of what's starting in the heart, what's actually going on in the heart as we look at these different waves. So when the P wave happens, that's when the atria contract. That's when atrial depolarization starts. So that's when we have that initiation basically of our impulse. Okay. And then as it travels through the PR segment here between the P and the Q, okay, that's when the contraction completes. So that's when atrial contraction or depolarization completes. Then we go into our QRS complex. This is, and you can see right in the yellow, this is where ventricular depolarization starts. So if you're looking here on the side, it tells you what each segment, because it shows you in green what's going on, and it shows you in yellow here where it's occurring. Everybody see that on this slide? Okay. So that's what's happening. Okay. So when you go down to the next one, when we start talking about our QRS complex, okay, then what's happening is that ventricle is depolarizing or contracting. And you can see the yellow on the heart here, right? It's showing you that it's going down the bundle of his and starting to go into the Purkinje fibers. And then it eventually goes through all the Purkinje fibers. So you have depolarization or contraction throughout all the ventricle. Okay. And then the last segment is the T wave. So that's this segment right here. Okay. And the T wave is where we start getting repolarization or relaxation of the ventricles. So that's what's going on in the actual heart. That's what each of these things is telling us about what's going on in the heart. Okay, so there is a set of steps that we use to interpret EKGs. The first thing we're going to do is identify the rate. And that, to identify the rate, if we go back here, right, if we look at our QRS complex, this is ventricular contraction right here. That's what's happening. That's what gives us our heartbeat when the ventricles contract. So for every QRS complex, that's a heartbeat. So in that 6-second strip, if we count how many QRS intervals we have, or QRS complexes we have here, and multiply that by 10, that gives us our heart rate. And we're gonna, again, we will do this. So we're gonna identify our rate. Next, we're gonna identify our rhythm. Our rhythm is either regular or irregular. A rate is going to be how many beats per minute. Our rhythm is either going to be regular or irregular. Those are only two choices. It's either a regular rhythm where it's nice and right, like when we feel it, it's regular, or it's going to be irregular. Those are only two choices. Okay. Next, we're going to identify that P wave. Okay. And we're going to go through each of these steps individually. Then we're going to measure that PR interval. We're going to measure our QRS complex, and then we're going to give our interpretation. And those are the steps. So we're going to start with identifying the rate. So this is a 6-second, right? 6-second. Here's 1 second. Between here and here is 1 second. Between there and there is my second, my third second, my fourth second, my fifth second, and my sixth second. So this is a 6-second strip. So I'm going to count the QRSs in my 6-second strip. And I have 1, 2, here's my second one, my third, my fourth, my fifth, my sixth, and my seventh. So I have 7 QR complexes in my 6-second strip. So I'm going to take 7 and multiply it by 10 because there's 10 6-second periods in a minute. So I'm going to take my 7, I'm going to multiply it by 10, and that gives me a heart rate of 70 beats per minute. So for this patient, the heart rate is 70 beats per minute. Okay. So I have my 6-second strip. I'm count my QRS intervals, and I have 7 of them. So I'm going to take my 7, I'm going to multiply it by 10, and that's going to give me my heart rate of 70 beats per minute. Okay. when I'm looking at the rhythm, okay, it's asking, do I have roughly the same amount of space in between each QRS interval? So if you look at this, you have 21, they counted them. You have 21 small boxes. 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 That means you have a regular rate. There's roughly the same amount of time between each box. Now, an easy way to do this is I will a lot of times, so if I have a strip and I don't have calipers and I want to know if something's regular, I will take and lay a piece of paper down on my strip and I mark on my paper with a pen where my first QRS is and then my second QRS complex, right? So if I, hold on. If I had paper like this, I would take a pen and I would mark the space between, hard to do. Can you guys see this? Kind of, I'm not, okay. There. I'm gonna mark where one QRS is and then where the next QRS is, okay? And then I can just move that and see, does it match up? I can just move it down to see, does it match up all the way down? Are you guys understanding what I'm saying?
Yeah, that makes sense.
Okay. I'm like, it's hard to show like on the camera sometimes, but that's what I do. I just lay that piece of paper down. And then on that piece of paper, I make the mark where this is, and I make the mark where this is. And then I pick up my piece of paper and move it to see, do those marks line up between this one and this one, and then this one and this one. And that tells me if it's regular. That's an easy way without counting boxes, because counting boxes can get tedious, I'm not gonna lie. That's a quick and easy way to know if your rhythm is regular or irregular. Okay. And remember, the good thing about that is you only have two choices, right?
Trump with nothing to stand. So I don't know where it's there's nothing like nothing to identify. Like, cause I came early and
Sorry?
when you go to Walmart, you check in, you check in where you put your sponsors at. You go to
Brandon, are you talking to me? Or do you mean to be muted?
sorry, my mic came off.
Okay. All right. So you only have two choices for rhythm. It's regular or it's irregular. That's it. Next, we want to identify the P wave. So remember I said that's the first wave we're looking for. Is a P wave present? Meaning, is it there? That's the first question we ask. Do I have a P wave? Well, I have one right here. I have one right here. I have one right here. I have one in front of each of my QRSs. So yes, I have a P wave in front of each QRS. Everybody see that? Okay. So, oh, I gotta let her in. Got it. Okay. So I have a P wave in front of each QRS. It asks me, are the P waves present and upright? Meaning a P wave that would go in the opposite direction. So sometimes you will have a P wave that instead of going up like these do, oh, sorry. Instead of going up like these do here, it would actually go down. It would invert, what we call invert. So instead of going up, it goes down. And so, and we'll talk about what it means when it goes down as we get into our rhythms. But just know that so I'm looking, do I have a P wave? Because if I don't have a P wave, that's going to tell me something different. Okay. So do I have a P wave? Is it there? Is it one in front of every QRS complex? And is it upright? And so those are the three questions that
So
I'm
if
going to ask. Go ahead.
if it's not upright, that's not considered a P wave.
It is still considered a P wave, but it gives us, when we start talking about how we interpret rhythms, some rhythms will have that inverted P wave. And so that will help us, that's going to help us determine what rhythm or what, rhythm, I guess, because that's what it's called. But it will let us know what rhythm our patient's in. So the first rhythm you're going to learn is normal sinus rhythm, but there are a bunch of different rhythms. And so we have to learn how to interpret this. And so that's why I said, like, this literally is a step-by-step process and memorization. You just have to memorize like if this is there, if this isn't there, what it means. And we're going to go through each of these. So trust the process and go through it with me. I promise we will get there. Okay. But that's what it means when it asks if it's present and upright. So there's one in front of each QRS, right? You can see it identifies that. And all of them are upright. None of them are inverted. Okay. So that's what we're answering. The next question that we're going to ask is measure that PR interval. So we're going to go in and we're going to go in and actually measure that space, right? We said the PR interval starts at the beginning of the P wave, so right here, and ends at the beginning of the Q. Okay, so right there. So now what we want to do is count our small boxes because this is our big box. Remember, we have the big boxes and we have the small boxes. So here's our big boxes, but we are going to count a small box because this is not a big box. So I have 1, 2, 3, 4.5. You see how that small box is cut in half? Everybody with me? That small box is cut in half. So we have 4.5 small boxes. Each small box is worth 0.04 seconds. So if we multiply 0.04 seconds by 4.5, 4.5 small boxes, you're going to come up with 0.18 seconds. So if I add 0.04 to 0.04, that gives me 0.08. If I add another 0.04, it gives me 0.12. If I add another 0.04, it gives me 0.16. And then a half is going to be 0.02. And if I add that to my 0.16, I get 0.18.
I thought each small box was 0.2 seconds.
Nope, each big box is 0.2 seconds. The big boxes. The small box is 0.04. So if my PR interval is 0.18 seconds, is that normal or abnormal?
Abnormal.
Normal.
It is normal because normal should be between 0.12 and 0.2.
Sure.
So 0.18 falls in between 0.12 and 0.2. Okay. So that's our next step. We're going to measure the PR interval. Okay. Then we're going to measure the QRS complex. So we're going to go in and we're going to, the QRS complex starts at the beginning of the Q and ends at the end of the S wave. This is my Q, R, S. Okay. So beginning of my Q to end of my S. And what you're going to see is that you have, this is where you use calipers because you can measure this and then bring it up where you can see the boxes clearly. But if you look at here, you have like one full, you can see in the center here between these two, we have one full small box, right? And then you have about a quarter of a box here and about a quarter of a box here. So they're taking that as a half. So we have 1.5 small boxes. So we're going to take 0.04 and multiply it by 1.5. And it's going to give us 0.06 seconds. So is 0.06 seconds normal for a QRS?
Yes.
Yes, it is. Yep.
Yes.
Okay. So we have a normal QRS complex. Okay. Now, what this slide tells you here is that when we see wide QRSs, so when that QRS is more than 0.12 seconds, that things that can cause that are things like electrolyte imbalances, drug toxicities, and PVCs, which are premature ventricular contractions. That's what PVC stands for, premature ventricular contraction. And we'll talk about what that is and identify it. So far, if we go back, okay, we started out, right? Oh, no, I went too far back. We started out by identifying the rate, which was 1. That was the first thing we needed to do. We identified our rate as 70. And then we identified our rhythm as regular. Then we said that we have a P wave for every QRS and they're upright. Then we measured our PR interval at 0.18 seconds, which is within normal. Then we measured our QRS complex, which is within normal at 0.06 seconds. All right, so far, everything we've done with this rhythm has been within normal limits. Okay. So now we're going to put it all together. All right. So in this one, if we look at this one, why did it give me a different? Oh, okay. So we're gonna put it all together. So it's gonna take this strip. Shoot. Guys, why don't we take, before we start this, because it's a new strip, let's take about a 10-minute, let's come back at 5 after 11, okay? Sound good? All right. Okay, I am back. You guys back with me?
Yes.
Okay. Yes. All right. So we're going to try and put it all together here. So we have this rhythm strip in front of us. It is a 6-second strip because we have, this is 1 second, this is 2 seconds, this is 3 seconds, 4 seconds, 5 seconds, 6 seconds. Okay. So they have one beat, so it's 1, 2, 3, 4, 5, 6 QRSs in a 6-second strip. So we're gonna take our 6, multiply it by 10. That gives us 60 beats per minute. Is that normal or abnormal?
Normal.
Normal.
It's normal.
Normal.
It's on the very low end of normal, but it is normal. Okay. Is our rhythm regular? So this is where again, in the, if you don't have calipers, I would hold my paper up there and I would mark it. But just by looking at it, it looks regular to me. I mean, if nothing else, you can see like every QRS is almost exactly in the same spot from the 60-second mark. Do you guys see what I'm talking about? Like if you look at where this is, it's like at the very end of the second box, at the very end of the second box, at the very end of the set. You see what I'm saying? So there's other ways that you can kind of look and see, but this one for sure looks regular. Anybody disagree with me? No. Okay. So our rhythm is regular. All right. So is there a P wave?
Yes.
Yes. Is there a P wave in front of every QRS?
Yes.
Yes.
Okay. And are my P waves upright?
Yes.
Yes. Okay. So we have identified our rate. It's 60 beats per minute. We have a regular rhythm and we have an upright P wave in front of every QRS. Everybody with me so far? Anybody need me to go back over? Okay. So then now we're going to start doing our measurements. So we're going to measure our PR interval. And so our PR interval is going to start, remember, at the beginning of our P wave. And it ends at the very beginning of the Q wave. So I am going to count my boxes in between. I have 1 box here, 2 little boxes, 3 little boxes, 4 little boxes, 5 little boxes. They come up with 6, okay? But they come up with 0.24. I don't know that I agree with that. I would probably count that as 5, which would make the PR interval 0.2 seconds. But we're going to go with theirs. They measured it. They must have brought it out a little further in each end. And so if we go back and look at if we bring it out a little further at each end, then 1, 2, 3, 4. I still come up with 5, but whatever. They come up with 6. Okay. Then we're going to measure our QRS. So our QRS, remember, is from the beginning of our Q, so this right here, to the end of our S, which is, there we go. The end of our S is right here, okay? So if we look at this, we have one box right here, one box right here, and one box right here. So see, they come up with 2 and I come up with 3. But that's all right. I'm telling you that those little differences aren't that big of a deal, because the truth is, even if we did 3 or 2.5, however you wanted to do it, it's still going to be okay. It's still going to be within that normal. Okay. But they came up with 2 boxes. And so that makes it 0.8 seconds. Okay. Is 0.8 seconds normal? For a QRS? Is that
Yes.
within? Yes. Okay.
Yes.
And so once we've done all that, this is where we interpret. Okay. And this is how we interpret this rhythm. So we are going to, let me stop annotating, go on to site 18. So we have a rate of 60, we have a regular rhythm, we have a P wave that's upright in front of every QRS. We have a PR interval of 0.24 seconds, and we have a QRS complex of 0.08 seconds. And because everything is normal, it is called normal sinus rhythm. So if you go through and your rate is between 60 and 100 beats a minute, your rhythm is regular, you have an upright P wave in front of every QRS, your PR interval is between, they've changed them. It used to be 0.2. What is it? The PR interval is 0.8 to 0.12 to 0.20. That's what I thought. So technically that's not normal. That's why I don't agree with it, but it is. We're going to say it is. Remember, I came up with 0.02. Okay. And then the QRS complex of 0.08 is normal. So QRS complex is 0.06 to 0.12. So everything is normal. It is called normal sinus rhythm. That's your interpretation. And now as we go through each rhythm, we are going to follow this same step, but something is going to change in one or more of these steps, and that is going to lead us to a different interpretation. So that's why I said it's really like you just have to memorize and then you have to follow the steps. Okay. So normal sinus rhythm is what we want our patients to be in. Okay. So so I am going to show you something. I actually brought it with me. Let me grab it really quick. When I went through my critical care classes back in the day, long time ago, but rhythms haven't really changed. This was my book. This was my binder that I had to learn. So these are all the rhythms that we had to learn. I don't know, there's like 40 some rhythms, I want to say, that we had to learn. But the way that because we had to take tests and all that. So the way that I did mine and helped study is I made flashcards. And so sometimes so like on one side I hadn't done the back side of these, but you will see I did what the rules were. So with this rhythm, these are the rules, and with this rhythm, these are what it looks like. So I just did my flashcards, and I just went through my flashcards over and over and over and over again. Now, on my flashcards, I had the rhythm, okay? I then had the rate. I had the name of the actual rhythm. I had the rate. I had the rhythm if it was like regular, irregular. I described what my P waves should look like, what my PR interval would be, what my QRS would be, and then underneath I put treatment. And sometimes I think on some of them I had cause too, like what causes it and then what's treatment. So, and my flashcards went with me everywhere. And those are actually newer ones at home. I didn't bring my old flashcards, but I had a stack like that of flashcards, and I just went through them, took them with me everywhere I went. So I always recommend flashcards because this is memorization. We don't say that too often in nursing school, right? Most of the time we're like, you're not going to be able to memorize this. You just have to like understand the concept. But this is one of the times I'm going to tell you, you have to memorize. You just have to memorize the rules. Okay. So normal sinus rhythm has a rate from 60 to 100 beats per minute, has a regular rhythm. Your P wave is upright, and before every QRS, your PR interval is normal, which is 0.12 to 0.20, and your QRS is normal, which is 0.06 to 0.12, I think now. It used to be 10, but I think it's 12 now. Where is it at? Yeah, 12, 0.06 to 0.12. So that is so if I had a card, I would actually probably put on one side normal sinus rhythm, and then on the other side, my rules, so that you can flip through either way. You can flip in through where you are. What's that? What, Rachel?
Oh, so sorry. I didn't mean to do that.
Okay, that's fine. So on one side you're going to have the interpretation, on the other side you're going to have the rules, and you can do it both ways. So you can flip it through the sides where you say, okay, normal sinus rhythm, that's a rate of 60 to 100, that's a P wave upright in front of every QRS, that is a right normal PR interval. So like you just run through it, or you can run through it where you're looking at this part of the flashcard, and then you come up with the rhythm. Either one of those will work, but it helps just to kind of like, because we're going to learn quite a few rhythms. Okay. So everybody good with normal sinus rhythm? Okay. All right. Now we're going to talk about, so normal sinus rhythm has no treatment, and the only cause is normal. That is what we want our patients to be in. That's why we call it normal sinus rhythm. That's what we want. Okay. Now the next rhythm that we're going to learn Sorry, guys, is sinus bradycardia. What does Brady mean?
Hello.
Well,
No. Yep, good. So, bradycardia is low heart rate. So, you have a rate below 60 beats a minute. Your rhythm is still regular. You still have a P wave that's upright and before every QRS. You still have a normal PR interval, which is 0.12 to 0.20, and a normal QRS, which is 0.06 to 0.12. The only thing different from sinus bradycardia and normal sinus rhythm is your rate. That's it. Okay? The rate is less than 60. Now, what are some causes for this? Vagal stimulation. So like when we stimulate the vagus nerve, that's why we don't do carotid massages anymore. Well, one of the reasons they say to do carotid massage to get a heart rate down, but the vagus nerve runs like through our neck. It runs through the middle of our body all the way down to our rectum. And this is why they don't want heart patients straining to have a bowel movement, because if they strain too much, they will cause vagal stimulation, which can drop their heart rate and their blood pressure, and then they can go into cardiac arrest. Okay. Athletes, and we'll talk about this in a second. And then medications, calcium channel blockers, digoxin, beta blockers. Those are very common causes of bradycardia, sinus bradycardia. So athletes, people, and I'm not talking about somebody who goes to the gym 3 times a week. Okay. I'm talking about athletes. So these are your professional athletes. These are people that are like, oops, sorry. God bless it, Brandy. Are like run miles every day. So these are people who are like true athletes, who are very, very well conditioned. And because they are so cardiovascularly conditioned, their stroke volume, right? The amount of blood that they put out in one stroke is high because their heart is that healthy. It relaxes right, it fills up, and it has a good ejection fraction of like 70%, sometimes even higher in well-conditioned athletes. And so it's pushing this significant amount of blood in one stroke. So if I can push double the amount of blood that you can push in one stroke because my heart's that healthy, then my heart rate's going to be lower than yours. And so athletes have a tendency to have much lower resting heart rates, okay? And because it's such an effective pump. And so it is not uncommon for athletes to have resting heart rates in the 50s. My oldest son used to run, he ran cross country and track and field, I don't know, 3 of his 4 years of high school. It might have actually been all 4. I don't remember. I had 3 boys and they were all bam, bam, bam. So I don't remember who did what all the time, but his resting heart rate would sit at like 53 because he ran miles every day. Every day he ran. He would run 3, 4, 5 miles every day. And so his heart was that conditioned and effective that his resting heart rate was in the 50s. So the one thing I always stress when we are talking about numbers or rhythms or objective data, remember that we treat the patient, not the numbers. Okay? Because an athlete may tolerate a heart rate of 53 without any problem, and there's no need for treatment because they are completely healthy. Whereas somebody who has a, is 70 something and their heart rate drops down to 50 something, they're not going to be okay. And so how do we know? How do we know if our patient's okay with a heart rate of 50 or not okay with a heart rate of 50?
Do they have other symptoms associated with it?
Yep. What are those symptoms?
Dizziness?
Okay. Dizziness. Yep.
Fatigue.
Fatigue. Okay. What else? You're assessing the patient. How do you know? What would tell you that they're not perfusing well?
Shortness of breath.
Okay. Shortness of breath. Absolutely. What
Wouldn't
else?
they just tell us they don't feel well?
They could just tell you that they don't feel well. Absolutely.
We can do their blood pressure and respiration as well. What are
Okay. So
vitals?
potentially vitals. You're definitely going to see in the heart rate. Their blood pressure may be reduced.
Skin color.
What else? Color. Very good. Cap refill.
Fossils?
Mental status. Right. They might be confused. If we don't get enough blood to the brain, it has a tendency to not work so well for us. Okay. So these are the things we're going to look at. We're going to look at that, like their color, their pedal or their peripheral pulses, their cap refill. Do they feel dizzy? Are they tired? Are they short of breath? Are they confused? Okay. Those things make them symptomatic, which tells me that they aren't tolerating a heart rate of 54. Whereas if an athlete comes in and their heart rate's 54 and they're alert and oriented ×3, they say they feel fine, their stomach just hurts. That's why they're there, because they have a stomach ache. But otherwise they feel fine. And their blood pressure is good. And their cap refill is great. And their their peripheral pulses are strong. That tells me that my patient's perfusing fine. I don't need to worry about that heart rate of 53. Now, am I still going to notify my provider? Absolutely. Okay. I'm going to let my provider know, hey, by the way, this patient's heart rate was 54 or whatever. And then I would say, but they're fine, and a lot of times if I see somebody has a lower heart rate and they look great and all that, I just ask them, like, are you an athlete or are you a runner? And a lot of times they're like, oh yeah, I run every day. And I go, okay, great. But I still have to let my provider know because it's out of norm. But I'm not going to be panicked about it. It's not going to be something I need to run and find my provider right away versus my patient who has a heart rate of 54, who's confused, can't tell me where they are, who has, a blood pressure of 80/40, who has decreased cap refill. That's a patient I need to get a hold of my provider right now. But both of them have a heart rate of 54. You see what I'm saying? It's not just the number. We have to assess our patients. Okay. So treatment. If your patient is asymptomatic, we don't treat them. If it's not broke, don't fix it. Okay. If they are asymptomatic, we aren't going to do anything but monitor them. If they're symptomatic and they are in a sinus bradycardia, there are 2 treatments. The first is atropine. And you do have to know the treatments for these dysrhythmias or arrhythmias. Dysrhythmia and arrhythmia are the same thing. It's like angina and angina. So atropine is a drug. It's usually given typically for bradycardia. We are giving this IV. Okay. And then if your atropine doesn't work, or if your bradycardia is so low that your patient's really not perfusing, we may do what's called transcutaneous pacing. So in like how many of you have seen a crash cart or a defibrillator?
I seen it at one
Uh,
of the
Most
clinicals.
Okay, most of you. So with the defibrillator comes patches, right? Back in the olden days we had paddles, but now we have patches. And so the patches either go one on the front, one on the back, or one here and one here. Okay. But you're going to put your patches on, and you are going to put it in what's called pacing mode. And so it's not going to shock them like we do if they are in cardiac arrest, but it is going to deliver enough electricity to, first you have to capture. So you will set it to pacing or sync mode, and then it will sync itself. You will see this little, when these come across your screen, when these little things come across your screen, there will be a little dot, a white light at the end of it that will happen. And so once you see that you have this white light every time a QRS comes up, that tells me that my machine has synced to my patient's rhythm. And then I am going to get ready to do pacing. And so what I'm going to do is I'm going to deliver enough electricity to initiate more QRS complexes to get that heart rate back up. So I'm going to pace them, but I'm going to pace them through patches. Unlike, eventually, if we can't find a cause and get this fixed, that patient may have to go and get a permanent pacemaker. Usually sinus bradycardia. Sorry. We can reverse sinus bradycardia because it usually is caused by something like, one of the most common causes is medications. Because, for example, I told you guys I have a rare heart condition. I take a lot of cardiac medications, a lot. And I'm on max dose on a lot of them. And so, but do I take my blood pressure every day or check my heart rate? Nope, I sure don't. I very rarely, do I actually check my blood pressure or my heart rate unless I'm feeling off or feeling weird or something. So what can happen is patients at home, they're not checking their heart rate or their blood pressures or whatever. And so they may not know that they're having side effects from their beta blockers and that their heart rate got too low. All they know is now they're just not feeling good. And so they come in and we see that they're on beta blockers, and okay, well, maybe their dose is just too high for them now and we need to back off on their beta blockers. Or maybe they're in DIG toxicity, and then we can fix that. So those are things that we can fix. And typically, if you fix the cause, the sinus bradycardia will resolve itself. It'll go away. Okay. Any questions about sinus bradycardia? Okay. Next, we're going to move on to sinus tachycardia. Okay, so sinus tachycardia. We have a heart rate above 100 beats a minute. Now, I don't see my tick marks. This one, oh, I can't really see them. This is a bad strip, but we're going to assume this is a 6-second strip because I don't see the marks. So I have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17. Although those are both on the edge. I would probably stick with 16. But so my heart rate's above 100. Okay, so 160. But my rhythm is still regular. So if you look at the distance between this, it's pretty close to the distance between that and the distance between these two. So that's a very regular rhythm you can see. And again, I could take a piece of paper and hold it up and mark it and march it out. Okay. So my rhythm is regular. I have a P wave in front of every QRS, like there's one, there's one, there's one. So you see there's a P wave in front of every QRS. Okay. Everybody see our P waves? Good?
Yes.
Okay. And it's they're all upright. So they're upright and we have one in front of every QRS. Our PR interval, if we measured that, I can tell you, I mean, by looking at it, I can tell you it would be normal. But if you just roughly look at it, it's like 2 boxes. So that's 0.08. So you're good. Now, a lot of times, like PR interval, it says normal is 0.12 to 0.20. When you get into faster rhythms, that's naturally going to shorten. And I don't consider something less than abnormal. It's when your PR interval gets longer than normal that it's a problem. Shorter than normal is fine. Okay. So even though I would guess that that's like 2 boxes, so it's like roughly 0.08, I would still consider that normal. And then we have our QRS, which again is like 1.5 boxes, maybe 2 boxes. So again, you have that 0.08, which is normal. So everything is normal except for the heart rate. The heart rate is above 100. Now it's sinus tachycardia. Okay. So what can cause sinus tachycardia? Lots of things. Some things we're not going to treat because they're normal. For example, exercise. When we exercise, most of us, our heart rate's going to go above 100, right? I mean, that's kind of the point of doing cardio workouts. We want to get our heart rate up. So are we going to treat a heart rate of 120 when somebody's running on a treadmill? Nope, because that's what their heart should do. Okay. Emotional distress. You're excited. You have a nursing exam. You have your first math exam, whatever. So anxiety and stress can cause our heart rate to go up. Now, we're not going to treat that per se, because the truth is your heart rate's going to probably go back down as soon as you're done taking your test. Okay. Those type of things are like normal responses. A fever. How would we treat sinus tachycardia caused by a fever?
Can give medication.
What kind of medication?
Antipyretic.
There you go.
Yeah, antipyretics, yes.
Antipyretic. We're going to bring the fever down, right? It's the fever causing the tachycardia. So we're going to bring the fever down and make sure they stay hydrated. Okay. We're not going to necessarily treat the actual rhythm. We're going to treat that underlying cause. Severe bleeding shock. Well, if they have severe bleeding and shock, then we have to treat that. So we have to get the bleeding stopped. We have to get, blood or fluid back into their vascular system. We have to treat the shock and get that reversed. Okay. Hyperthyroidism. Well, we're going to treat that with medications. They'll give them medications to hopefully get that thyroid reduced, because remember, thyroid hormones control the metabolic rate of every cell in our body. So when somebody has hyperthyroidism, they're going to have a high blood pressure. They're going to have a high heart rate. They're going to be anxious. They're going to lose hair. It's just as bad as not having enough. And then we have things like our stimulants. So this is caffeine, any type of chemical stimulant like cocaine, anticholinergics. I can't come up with my word. Like Adderall, Ritalin, those type of things. Okay, those can all cause some tachycardia. So just like sinus bradycardia, we are not going to really treat sinus tachycardia if it's asymptomatic. Like I said, if somebody's exercising on the treadmill, we're not going to treat a heart rate of 120. We want them to have a heart rate over 120. Okay. So symptoms can be things like that are, if you look at it, almost similar to symptoms of sinus bradycardia, right? Shortness of breath, dizziness, headache. They may feel like the palpitations, like their heart's racing, those type of things. Okay. Treatment, we really want to find the underlying cause and treat that, because otherwise we're just putting a Band-Aid on, and that Band-Aid's not going to get us far. Okay. Beta blockers or calcium channel blockers, if our patient is very symptomatic, we need to get that heart rate down. We're going to give some type of NSAID or antipyretic for a fever. And if they're hypovolemic, we're going to give fluid resuscitation. Any questions about sinus tachycardia? Okay, so you have learned 3 rhythms. You have learned normal sinus rhythm. Normal sinus rhythm is a heart rate between 60 and 100. It is a regular rhythm. You have an upright P wave in front of every QRS. You have a PR interval that is 0.12 to 0.20. You have a QRS at 0.06 to 0.12. That's normal sinus rhythm. If you have sinus bradycardia, you have a regular rhythm, you have upright P wave in front of every QRS, and a normal PR interval and a normal QRS. The only difference is your heart rate is below 60. If you have sinus tachycardia, your rhythm, P wave interval, PR interval, and QRS are all normal. The only thing that is abnormal is your rate, and it'll be above 100. Is it starting to come together a little now?
Yes.
Okay. I was like, I'm like, I promise, guys, trust the system. Trust the system. It'll happen. Okay. So you have to know normal sinus rhythm, sinus bradycardia, and sinus tachycardia. You will have to know these rhythms. All right, let's practice. So somebody give me the rate. And this is a 6-second strip.
110.
All right. Good job. Everybody see that?
Yeah, 110.
110. Okay. Is the rhythm regular or irregular?
Regular.
It is regular. Correct.
Good.
Everybody see that? Let me get into my chat. Okay. Tell me about the P wave. What's our P wave look like?
Present and upright.
Okay, present, upright, and in front of every QRS. That will be important later. So don't forget that third part. Present, upright, and 1 in front of every QRS. Okay. What's your PR interval? You're just gonna, if you can see, they've down here, they kind of gave you a blow up of it. So they're starting it here at the edge of this, and then it'll be somewhere in here. So how many blocks is there, you think?
Looks like 4.
3.5 or 4.
Okay, so what is 4 times 0.04?
0.16.
Very good. Is that normal?
Yes.
Yes, it is. PR interval is 0.12 to 0.20.
Okay. Yes.
Yep. Okay. All right. What's our QR complex now? Let's look at that. Erase these. All right. So if we are looking at our QR complex, it's going to start right about in here. Oops. And then it's going to end over here. Remember? How many squares do we have in there?
I can't tell if it's 3 or 4.
I know. They're saying 3.
Yeah, it looks like 3.
Okay, so 3 times 0.04 is what?
0.12.
Very good. Is that normal?
The last normal, yeah.
Yes, that is normal. Correct. That is normal for a QRS. So what rhythm do you have?
Sinus tachycardia.
Yes, good job. Sinus tachycardia. Okay. So what can cause sinus tachycardia?
Exercise.
Exercise. Yep.
Fever.
Fever.
Fever. Yep.
Stress,
Stress. Yep.
stimulants,
What's that? Stimulants. Good job. Yep. Okay.
Hypothyroidism.
Yeah. All right. What if your patient is symptomatic? What are some symptoms they can have?
Dizziness.
Mm-hmm.
headache,
Headache,
Palpitations.
palpitations. Good job. What do we do if the patient's symptomatic?
We treat them
Yep. And how do we treat them?
depending the cause.
Yep. We find the cause and we treat the underlying cause. Good job. See, you guys got this. I know in the beginning you're like, oh my God, I don't understand this. But like once you start putting it together, it makes more sense. I promise. Okay. Next practice. All right, let's look at this one. I'm going to let you guys work. I'm going to let you guys work through this individually. And then I want you to put in the chat what rhythm you think you have. If you need me to mark or help count blocks for you, let me know. Okay. So I had a couple of people ask about rate. I put the rate. The rate is 80. You guys, the couple people who put in here are correct. Rate is 80. Yep.
Is it 80? Because that last one, you can't really see the full one. So that's
It is still 80, yeah. And here's the other thing I'm gonna say. Whether you count it 75 or 80 or 70, it's still all gonna fall in that same range. Good job, guys. You are correct. This is normal sinus rhythm. So the rate is 80. It is a regular rhythm. Your P waves are upright and you have one in front of every QRS. Your PR interval they measured at here, I'll look at it. 1, 2, I would say 3.5 to 4. So that would be 0.12 to 0.14. So either way, it's within normal. My QRS is like a box and a half, so like 0.06. So that's normal. So everything's normal. And that is normal sinus rhythm. What causes normal sinus rhythm? Life. Yep.
Nothing causes it. It's not.
Being healthy. All right. All right. So We don't do anything for this rhythm because that's a rhythm we want our patient to be in.
And I said, yeah, I have a black pair too. And she said, are they green? And are they like kind of like green? And I said,
Amber, I don't know if you know that your mic is on. There we go. Okay. All right, let's do this next one. I'm gonna let you guys do this one. Good job, guys. Mm-hmm. Yeah. Okay, so the rate on this is 40 beats a minute. The rhythm is regular. The P wave is upright, and you have 1 in front of every QRS. The PR interval, I think I counted like 4 squares, which would be 0.16, which is normal. And the QRS, I think I got 2.5, which would put it at 0.08 or 0.1, both of which are normal. So everything is normal except for the rate. The rate is low. So we have sinus bradycardia. Okay. What can cause sinus bradycardia?
Athletes.
Athletes. Although most athletes are not going to have a heart rate of 40, but overall sinus bradycardia can be athletes.
Certain medications.
Medication.
Vagus stimulations.
What's that?
Digoxin.
Yep. So medications. Yep. Digoxin, beta blockers, calcium
If there's
channel blockers.
problems with the SA node,
Mm-hmm. Yeah. If there's problems with the SA node, yes. Vagal stimulation. Don't forget about that, because that can happen with your cardiac patients. That's why I cannot tell you how many codes I went to, because when I worked in ICU, one of the ICU nurses from each of our ICUs in the hospital was part of the code team. And I can't even tell you how many codes I've been on in the bathroom, on the toilet. I mean, they weren't on the toilet anymore, but they had been on the toilet, and they were in cardiac arrest on the bathroom floor. So if you have a cardiac patient, do not take them off the monitor for them to go to the bathroom. I get it. Nobody likes to poop in a bedside commode, but they have to be on monitor when they need to go to the bathroom, because we need to know what's going on with their heart. Okay. What are the signs and symptoms of poor perfusion due to bradycardia?
Syncope, confusion.
Syncope, confusion. What else?
Fatigue.
Fatigue,
Dizziness.
dizziness. What's your assessment going to look like? What's their skin tone going to look like?
Pale,
Pale. Sweaty.
Pale. Cap refills probably going to be delayed. You're going to have weaker peripheral pulses. Usually not flushing. More flushing you're going to see with the tachycardia more, and then pallor is what you will see with your bradycardia. Okay. All right, one more and then we'll go to lunch. All right, interpret this one. Okay. Yes, heart rate is 60. Rhythm is regular.
It looks like two P waves to me.
It does look like two P waves, and what I'm going to say is it could be artifact or the way that the leads are placed. Because it's regular, and when we start talking about atrial dysrhythmias, we'll talk about why I know this isn't atrial fibrillation. And the reason I know it's not atrial fibrillation is because my rhythm is regular. And atrial fibrillation always has an irregular rhythm. And we'll see that. I think this is probably like lead placement or what we call artifact. Okay. But yes, but there it is upright. It's in front of every QRS. The PR interval looks like it's what, about 4 boxes again, maybe 5, which would be 0.2, which is still within normal. My QRS complex looks like it's about maybe 3 boxes. So that would be 0.12, which is again normal. So what's our rhythm?
Normal?
Normal sinus rhythm. All right. Do we treat normal sinus rhythm?
No.
No, because that's where we want them to be. All right, guys, let's take lunch. If you need to work on your math, you can do that. Let's come back at 12:35. We'll get through some more rhythms, and then I'll turn you over to Miss Angie. But try and get that math stuff done because she will kick you out, and you won't be able to take your math quiz, okay? All right, I'll see you guys back in 30 minutes.
Thank you.
You're welcome. All right, I am back. Everybody here with me?
Yes.
All right, see
I'm
some.
here.
All right, there we go. Okie dokie. All right, so our next practice one, I went ahead and advanced. So we're on slide 27 now. So we're gonna look at this one. What's your rate? What's your heart rate?
50.
Yep, 50. Good job. So we have 1, 2, 3, 4, 5. So 5 times 10 is 50. Is your rhythm regular or irregular?
It's regular.
It is regular. Okay. What about your P waves? Do you have a P wave in front of every QRS?
Yes.
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 Okay. And are they upright?
Yes.
Yes.
Yes. Okay. So then what is your PR interval? So I would here, let me hit annotation on this one again. So remember that in real life, because these are real strips, guys, remember in real life, people do things, they move around, they get sweaty, maybe they have chest hair and somebody didn't shave it. So you will get what's called artifact, meaning it causes like squiggles in that isometric line or baseline that really isn't caused by electrical activity. It could be them moving around. So there's just a lot of things that can kind of interfere. So it's not always going to look perfect. I wish it did, but it doesn't. So for this, I probably, because when I look at this, so like if I look at this P wave right here, right, versus this P wave, this makes me think that this is the real P wave and not this. That these little, see how this one right here too, it doesn't really have, it comes back to that isometric line versus this one has that extra squiggly. That's telling me that this is probably some type of artifact or movement, that extra squiggly. Are you guys with me? Thumbs up?
Yes.
Okay. All right.
Yes.
Okay, so I am going to actually start my measurement for my PR interval here, okay? And I'm going to end it about here, probably, okay? And so that gives me what? 1, 2, 3, 4 boxes. So 4 times 0.04 would be 0.16. Is that a normal PR interval?
Yes.
Yes, it is. Okay. So now we're going to measure our QRS. So if I measure, like I said, about right in there, okay, and then I stop it about right here where we come back to or close to back to my isometric line, I have like 1, 2, 3, maybe 4. So let's split the difference and call 3.5. So 3 times 0.04 is going to be 0.12. I add another 0.02 for my half of a small box, and that's going to put me at 0.14. It might be a little wider than normal, but I'm not going to call that abnormal. Okay, because we're close. And I don't have calipers. Now, if I had calipers and I was measuring exactly, I would be a little bit more confident in my measurements, but I don't have calipers, so I don't have that. So remember, we're doing like really rough. And so the fact that I'm guessing 0.02 over is not concerning to me. Are you guys understanding like why I'm saying that it is normal? Okay. So I would say that my QRS complex is normal. So everything's normal and I have a rate of 50. What do I have?
Sinus bradycardia.
Sinus bradycardia. Good job. This is definitely sinus bradycardia. So remember to go back with and know like what causes this. What are the signs and symptoms? And then what do we do? Remember, we only treat if they're symptomatic. And a lot of times your symptomatic is going to be poor perfusion. So if they're symptomatic with this bad rhythm or a different bad rhythm, either way, they're still not perfusing. It's a rhythm that's causing them decreased perfusion. So your signs and symptoms are going to be the same. You know, they're going to be pale. They're going to be possibly confused. They're going to feel dizzy. They're going to have, you know, poor cap refill. They're going to be possibly cool. Like, so those type of things are going to be, that's signs of poor perfusion, and more than one rhythm can cause poor perfusion. I just want you to think of it like that, because then you're not trying to memorize these signs and symptoms for a lot of rhythms that really have the same signs and symptoms, because the signs and symptoms are from poor perfusion. Any questions about that? Okay. And we have one more rhythm that we're going to practice here. All right. I'm going to let you guys do this one. And tell me what you come up with. Oh, sorry. Any guesses? Anybody got their rate yet? What's the rate?
130.
130
Yep, 130. Good job.
regular reading.
It is a regular rhythm, correct?
Sinus tachycardia.
It is sinus tachycardia. We have P waves. They're upright. There's a P wave in front of every QRS. Our PR interval, I roughly got 0.12. Was anybody not close to that? You don't have to get exactly, but close, because like I said, we're doing this rough. Okay. QRS complex, I got 0.10. Anybody have any problems with that? Okay. So again, go back and look at what causes this. When and how do we treat it? What do we do? What are those signs and symptoms? All right. How do you guys feel about your sinus rhythms? Normal sinus rhythm, sinus tachycardia, and sinus bradycardia. All right. Do you guys feel a little better now that from the beginning when I was just talking about the boxes and all these waves? At least now you kind of understand why we do it the way we do it.
Yes.
Okay. All right. So now we're going to start talking about atrial rhythm problems. So what that means is that the dysrhythmia or the not normal rhythm initiates in the atria, not the sinus node, because the sinus node gives us our sinus rhythms. And that is our normal sinus rhythm, our sinus bradycardia, and our sinus tachycardia for you guys, okay? There are other sinus rhythms, but we're not going to cover those. So when we say that we have atrial rhythm problems, that means that impulse is originating somewhere else in the atria. So it's like a rogue cell that is starting an impulse it's not supposed to start. Okay. There are two types of atrial rhythms that you guys are going to learn. That is atrial fibrillation. Oh, I take that back. There are 4 types of atrial rhythms you're going to learn. I'm like, wait a second, there's more. But there's 4 of them. So there's atrial fibrillation, atrial flutter, junctional, and supraventricular tachycardia, or SVT. So these are the 4 rhythms that 4 atrial rhythms that you're going to learn. Okay. So remember how I was talking about those P waves that had those extra little squiggles in them, right? And I said that there was a couple of ways that I knew that it wasn't atrial, that it was a sinus issue and not an atrial issue. And that is because when we have atrial problems that cause those extra P waves, it is either an atrial fibrillation or an atrial flutter, okay, one or the other. And when we have the extra P waves, and neither of those have regular rhythms. So once I see that I have a regular rhythm, I know I'm automatically taking out atrial fibrillation or atrial flutter. When I see that I have an irregular rhythm, my first thought is either atrial fibrillation or atrial flutter. Okay. So if we look at these right here, you will see this is atrial fibrillation, and see how this is not like this one and this one are really close together, right? And then these 2 are really far apart. And then these are maybe a little closer, and then these are really close again, and then these are really far apart. You can see the difference, right? There's no regular rhythm there. Okay, so that is my biggest clue that I have an atrial dysrhythmia. Okay, so in atrial fibrillation, what is happening is the sinus node may or may not be firing, but there's all these other cells in the atria that are trying to initiate impulses. And so you have the atria firing all over the place. And what happens is instead of getting a good contraction from the atria, it fibrillates or quivers because it's like chaotic. You have all of these impulses being initiated. And that's why it's called atrial fibrillation. If you look at where your P wave should be, what you will see is you see how you have just all these little squiggly lines or P waves, right? That I'm trying to get it. Let me see if I can get it. I'm trying to get it thinner. But do you see like all of those little squigglies? And there's no real clear P wave. There's a bunch of them, right? Because the atria is firing from all over the place. And it's causing the atria to fibrillate and not contract. Fibrillate is just a way of saying quivering. Okay. When we have atrial fibrillation or AFib, people you will hear it's frequently called AFib in the field. Okay. There's either controlled atrial fibrillation or uncontrolled atrial fibrillation, and that is determined by the heart rate. So, here's the problem. In real life, if you had a patient that had a rhythm like this, you would find the shortest, the two that are closest together and measure the squares between them and get your heart rate. And then you would measure the ones that are the pair that's furthest apart, count your squares and get your heart rate. And you would give a range for your heart rate. So maybe your range would be your widest square. Maybe that would put your heart rate at, let's say, 92. But your closest ones would put your heart rate at 125. Well, then you're going to say that your heart rate is 92 to 125. Okay. But for our purposes, you are just going to count in the 6 seconds like we taught you to. Now, in real life, would you take this patient's pulse and multiply it for 15 seconds and multiply it by 4?
No, few minutes.
No, you have to do the full minute. Okay. When you have an irregular heart rate, you have to do the full minute. I just wanted to make sure you knew that. So, but we're going to do the quick version. And we're going to say we have one. I don't know if I would count this one on the very edge or not. I don't know. I probably wouldn't because I don't have the whole complex there. So I'd probably start here and go 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. So what's my heart rate?
130.
130. Okay. So is that controlled or uncontrolled?
Uncontrolled.
Uncontrolled. Okay. My rhythm is irregular. Okay. My P wave is unidentifiable. I couldn't spit that out for some reason. Meaning I can't really pick a consistent, normal, upright P wave. Okay. I can't identify one. If I can't identify a P wave, I can't measure a PR interval. I have to be able to identify a P wave to start the measurement of my PR interval. So my PR interval is unmeasurable. Now, I can go in and measure my QRS. I can't see these blocks, to be honest with you, because this is tiny. But if I had to take a guess, I'd say maybe there's 2 small blocks, so I'd put it at maybe 0.08, which is normal. Okay. Or maybe even less. I don't know. It might be less, but my QRS is okay. It's within normal. So because I have these squiggly lines, it is irregular. I can't identify a P wave. I can't measure a PR interval because I can't identify a P wave. and I have a normal or narrow QRS. Okay. Now, in comparison, a flutter is also irregular, but it looks like a sawtooth. You can identify your P waves. Do you see how this looks like a sawtooth? Like the blades of a saw, the teeth of a saw, right? And you can actually count them. So there's like 1, 2, like right here, I'm like 1, 2, 3. And then here, that's my T wave. So I'm going to go 1, 2, 3. And then I have 1 in here. The other one might be buried underneath. Again, right here. Hold on just a second.
See, Samoa is here, and she's here to take an ATI for her leadership class, and there's no proctor.
Shatoya hasn't done that.
So I can have Tony sit in there.
Yeah, get her started. I don't know what I'm gonna do then if Shatoya didn't show up. Okay.
Okay.
All right, thanks. Okay, so, but you see how you can count these. So again, here, you can count them. That's your sawtooth. So this looks it looks different. You can see the difference in the look of the P waves, right? Is everybody with me? They're both irregular, but this one you can actually identify your P waves versus you can't really identify your P waves here.
I'm trying to learn about arterial fibrillation, but our internet keeps going out.
Get out of there now.
Okay, so I don't think he was talking to me, so I just muted him. So that's the difference between these two. And so when we're talking about what's actually going on in the body, that is that with atrial fibrillation, we have all these chaotic cells firing and initiating our impulses. With atrial flutter, you only have a few. So you might have like just 3 other spots that like to fire and give you, so they do give you a consistent P wave and you get an atrial contraction. It just isn't, you're getting too many of them. Are you guys okay with the understanding the difference with those? Okay, and sometimes with atrial flutter, it can actually be regular. They can have a complete like 3-to-1 conduction, meaning that the atrial, 3 different spots, and well, the sinus node and then the 2 other spots in the atria are firing consistently. But the AV node, which is a gatekeeper, is only letting 1 of those 3 through. And that's why we call it the gatekeeper, because if there's too much coming from the atria, it'll be like, no, I'm not letting all of you through. This is crazy. You can't all come. So it'll only let a certain amount through. And that's what happens in atrial fibrillation and atrial flutter. Okay. Again, with both of them, under 100 is controlled, over 100 is not controlled. In atrial fibrillation, they well, in atrial flutter too, but you don't see it as much. In atrial fibrillation, they can actually get their heart rate into like the 130s and the 140s and the 150s. And they will call that atrial fibrillation with rapid ventricular response, or AFib with RVR, because we like to talk in acronyms in medicine. Okay. So if you look, the rate is going to be 1 2, 3, 4, 5, 6, 7, 8, 9, 10. So if I have 10 complexes, what's my rate?
100.
100.
Good job. So is that controlled or uncontrolled?
Controlled, even though it's at the X-ray.
Right, it is controlled, yeah. And then you see the regular with atrial fibrillation, we say that's unidentifiable P waves because you can't really identify them. Whereas with atrial flutter, we call them sawtooth flutter waves. That's how we describe our P waves. Either one of those, for both of those, our PR interval, we can't measure it. If I'm having multiple P waves, I can't measure a PR interval. Okay. And then the QRS is still within those normal limits. So what can cause these things? Well, coronary artery disease can cause atrial fibrillation or aflutter. Heart failure is a common cause of either of these. Atrial fibrillation is way more common than atrial flutter. Like I would say, like probably for me, I would say for every time I have an atrial dysrhythmia between these two, I would say out of 10, probably 8.5 to 9 of them are atrial fibrillation. Atrial flutter is not as common. COPD, hypertension, post open heart surgery because we just cut into the heart and irritated the crap out of it and it's not happy, is very common for patients to go into atrial fibrillation after open heart surgery and or post cardiac cath because again, we went in and messed with the heart. The heart doesn't like that. Okay. Symptoms: palpitations, shortness of breath, dizziness, chest pain. They may have chest pain, anxiety. They may just feel anxious. They don't know why. They can also be completely asymptomatic. Okay, completely. They can come in and we find it by chance. I'm sorry, yes, I can let you in. Okay. So it can be, they may not have any symptoms. Treatment. If they're symptomatic, we're going to get them on oxygen. If we know how long they've been in atrial fibrillation or atrial flutter, like if we know it's been a very short amount of time since they went in, we will do what's called cardioversion. And what that is we actually shock the patient or shock the patient. I don't know why. So we shock the actual patient, but we shock them with a lower amount of electricity and we shock them on a specific part of the rhythm. So remember how when I was talking about pacing somebody and how you put your defibrillator in synced mode and how you get that little dot on the top of each QRS that lets you know that your machine is synced to your patient's specific rhythm. You have to sync to do cardioversion. Otherwise, you are just shocking your patient at any point in the rhythm and you could hit them on that T wave, that ST segment or T wave, and put them into complete cardiac arrest. So you absolutely cannot do cardioversion. Think of it this way. If your patient's awake and talking to you, it needs to be synced. Okay. So we're going to sync our defibrillator, and then we're actually going to hit shock. But the shock, it may not shock as soon as you hit the button. There will be a delay, and that delay is going to be because it has to hit in a certain part of that rhythm. Okay? So we can't do that. Like, we're not fast enough to do that as human beings, and that's why the machine does it for you. Now, if your patient is stable, meaning we know they're in atrial fibr flutter, and we do need to get them cardioverted, but their vital signs are pretty stable. They're not showing signs of decreased perfusion. We want to ask our provider if we can get a little something to help relax them, because cardioversion is going to hurt. It is a shock. It is an electrical shock that we deliver to the heart, and it is painful. So if we have time, if we can, we try to medicate our patients and give them something to help them kind of like relax. However, if my patient is unstable and showing signs of poor perfusion, I can't do that. I can't give them some type of sedative or something to help them relax, because they're probably code at that point. So for those patients, unfortunately, we are just going to shock them, and it hurts. Now, it's not good. The pain isn't going to kill them, but it's unpleasant. So I debate. To me, it's an individual basis of whether or not I tell my patients it's going to hurt or not. Because some patients, you tell them ahead of time, and then it's like a big deal. And so you're just better not saying anything and dealing with with afterwards, because you have to do it. Or they're going to decompensate and die. And then we are going to be shocking them anyways. So, but that is synchronized cardioversion. If my patient's awake and talking to me, I am going to be doing synchronized cardioversion. If my patient is confused, unstable, or not talking to me, well, actually, if they're confused or unstable, I am still doing synchronized cardioversion. If they are unresponsive and have no pulse, that's when I go to straight shock, unsynchronized. Okay. Medications that we use to treat AFib and aflutter, beta blockers, because one, they keep the heart rate down, and these rhythms frequently go into tachycardias. And metoprolol is a common one. Our calcium channel blockers like cardizem, and we will use that acutely for sure. Antiarrhythmics like amiodarone and digoxin. If we don't know how long a patient's been in atrial fibrillation, because the atria quiver instead of contracting, their blood pools in the atria. It doesn't kick all the blood out. And that pooled blood that sits in the atria can clot. And so if we don't know how long that patient's been in atrial fibrillation, we don't cardiovert them until we've anticoagulated them. Because if we cardiovert them and there's a clot sitting in that atria, and we convert them back to sinus rhythm, and that atria contracts like it's supposed to in sinus rhythm, it will kick that clot out. If that clot was sitting in the right atria, that clot's going into the right ventricle, and then where is that clot going?
Your heart or the lungs? Your heart?
Lungs. It's absolutely going to your lungs. Okay. If it's sitting in the left atria and you kick it out and it goes into the left ventricle, then where is it going? It's going anywhere. It could go to the
In the
brain,
body.
cause a stroke. It could go to arteries of the bowel and cause an ischemic obstruction. It can go into the liver and cause an infarct. It could go into the leg and cause occlusion. It can go anywhere. So this is why patients who have chronic AFib or patients who we don't know how long have been in AFib, we don't cardiovert them and we get them on blood thinners. Now, if somebody comes in an AFib and we don't know how long they've been in, they are probably going to admit them. They're going to anticoagulate them and then try and cardiovert them, but not until we get some anticoagulation on board. Does that make sense? Okay. Let me see if Miss Angie's going to be jumping on.
I'm here, ma'am.
Oh, I didn't realize you were there. And I'm getting ready to go.
I was just waiting for you to finish up.
Okay. I was looking. I'm like, did she not come? I must have missed you. All right. Well, I am done. We will pick up, guys, on Monday. We will pick up and start talking about junctional rhythms, okay? I'm going to mute myself and let Miss Angie take over. If I
Thank you.
remember how to do that. There we go.
All right, how's everybody doing today? Are you learning lots? Is your brain? Are you all brain dead? Yeah,
Yes.
a little bit.
Pretty close.
It's okay. EKGs is a lot, but the nice thing is when you guys go to clinical, right? When you're when you guys go to clinical now, we can spend some time and we can look at the monitor and the rhythms, and you can get a little bit better understanding. Okay.
I talked to them about and maybe if you could show them because we were talking about being able to pick up the difference between a true problem with a P wave versus artifact.
Oh, for sure.
If they could,
for sure,
yeah, see that in real life, that would be awesome.
Yeah, definitely. That'll be super easy to do.
Yeah.
All right. Give me 1 second here. Brandy, do you record yours?
I'm on mute. Yes, mine are being. But later, I need you to help me remember how to post this because I can't remember how to post it in Brightspace.
Okay, so what I need you to do
is stop
I
recording.
need you to stop recording for right now, please.
Okay. Let me see. I'm going to turn off transcription. Let me turn that off. Okay. Pause the transcription. And then I got to remember how to turn off the recording.
If you pause it, it's fine. Once we're done and we log off, then it'll, because it's paused, it's not going to record.
How do I pause it? It's still recording.
Under more,
Under
you should
more.
be able to do